Bupivacaine, or the trade name MARCAINE, is available in several concentrations: the 2.5%, which is 25 milligrams per milliliter, available in 10, 30, and 50 milliliter vials. 5%, or 50 milligrams per milliliter, is available in 10, 30, and 50 milliliter vials. And then 7.5, which is 75 milligrams per milliliter, available in 10 and 30 milliliter vials. Bupivacaine is an AMIDE local anesthetic agent. Local anesthetics effectively block voltage-gated sodium channels by binding to domain 4 at segment 6 of the channel. As a result, action potential initiation and propagation of impulses through axons and other tissues is diminished and effectively stopped. The structure and binding of local anesthetics. All local anesthetics are formed of three critical components: a tertiary amine group attached to an aromatic ring through an intermediate bond. Local anesthetics are bases and are charged when in solution. There's a dynamic equilibrium between the charged and uncharged form. When administered into a more basic environment, local anesthetics lose their charge and are in the uncharged form. The uncharged form is lipophilic and able to cross the lipid bilayer of the cell. After crossing the lipid bilayer, local anesthetic picks up the charge, and the lipophobic moiety binds to segment 6 of domain 4 of the inside of the voltage-gated sodium channel. The local anesthetic prefers the inactivated conformation of the voltage-gated sodium channel. However, local anesthetics can bind to the open conformation of the channel as well. Lipophilicity delivers the local anesthetic to the receptor, and lipophobicity keeps the drug there. Once the local anesthetic is bound, the inflow of sodium is stopped through the channel. This is the structure of bupivacaine. There's the aromatic ring, tertiary amine group, and the intermediate bond. All local anesthetics are bases. Bupivacaine's pKa is 8.1. They're charged in solution, so the pH of the solution is 4 to 6.5. When administered into the more basic environments, it loses its charge. It's able to then cross the lipid bilayer. It then picks up the charge and can bind to the segment 6 of domain 4 of the voltage-gated sodium channel. This arrow represents where the segment 6 of domain 4 would be located. This is an animation depicting bupivacaine that is uncharged, crossing the lipid bilayer. It is now picking up the charge and binding to the inside of the voltage-gated sodium channel. Typically, an action potential impulse propagates down an axon of a neuron, one segment at a time, or from cell to cell. Once the action potential reaches an area of the cell or the axon, the voltage-gated sodium channel opens and sodium rushes into the cell, making the charge inside the cell more positive than the outside of the cell. Once a certain voltage is reached and summated at the axon hillock, the threshold to initiate an action potential is generated and it propagates down the axon. Here's the axon hillock. Once enough stimulus is there, the sodium channels open and sodium rushes into the cell, making the inside of the cell more positive than the outside of the cell. This propagates down the length of the axon in one direction. That is how information is transferred from periphery to the CNS, and information is transferred from the CNS to the periphery. And this is representative of the sodium channel. So the voltage-gated sodium channel, the action potential reaches it, it then opens, sodium rushes into the cell. And now the inside is now more positive than the outside of the cell. Typically, local anesthetics create resistance by stopping the influx of sodium through the voltage-gated sodium channel. The sodium influx is necessary for the continuation of the action potential propagation. Blocking voltage-gated sodium channels slow the entry of sodium into the segment of the axon and slow or stop the conduction of the action potential. If you stop the action potential, you stop transmission of information from the nerve to the brain, and you would also stop transmission of information from the brain to the nerve. And this is how bupivacaine works. It once again goes into the cell, blocks the channel, the action potential is there, and then sodium is now unable to enter the cell. Therefore, the charge remains the same, and there is no propagation of action potential. Local anesthetics can effectively block the conduction of action potentials through all nerves, but nerve fibers differ in their susceptibility to local anesthetics, depending on the size, position, and degree of myelination. Local anesthetics preferentially block smaller diameter nerve fibers because the distance they have to passively propagate and the action potential is shorter. The position in the nerve bundle has an effect on the rate at which the nerve will be blocked. The nerve fibers around the circumference of the nerve bundle will be exposed to the local anesthetic first and be the first to be blocked. In myelinated neurons, action potentials are conducted in a saltatory fashion along the nodes around VA. Voltage-gated sodium channels are concentrated in these nodes around VA along the axons. In order to entirely stop transmission of an action potential in the myelinated neurons, you must administer enough local anesthetic to block 3 of these nodes around VA. The order in which nerves are blocked. The first to be blocked will be the B fibers, which are on the outside of the nerve fiber itself, and these are the preganglionic nerves. The C fibers transmit pain, and they're sympathetic postganglionic nerve fibers, and they're the smallest, unmyelinated. The A delta are the pain and temperature sensors, and they are lightly myelinated, and they're near the outside of the nerve fiber itself. The alpha, gamma, alpha, the A beta, and A alpha are muscle spindles, touch and pressure, and proprioception and motor neurons. Bupivacaine dosing. There's different doses needed and used for different types of uses for bupivacaine. Local infiltration would call for 0.25 to 0.5% bupivacaine. Peripheral nerve block, 0.25 to 0.5. Sympathetic block is 0.25. Epidural anesthesia is 0.25, 0.5, or 0.75% bupivacaine, although the 0.75% is not FDA recommended for obstetrical anesthesia. IV regional is not recommended for bupivacaine because of the low therapeutic index of bupivacaine. The peak and onset of bupivacaine for local infiltration is 0.25 minutes. Peripheral nerve block is 20 to 30 minutes. Epidural anesthesia is 15 to 20, and caudal is 15 to 20. The duration of bupivacaine for local infiltration is a long duration. It's 120 to 240 minutes. Peripheral nerve block is 360 to 720 minutes. Epidural anesthesia, 180 to 350 minutes. Caudal is 180 to 350, and spinal is 90 to 220. AMIDE local anesthetics such as bupivacaine are metabolized in the liver by the CYP450 enzymes. This enables the metabolized local anesthetic to then be excreted by the kidneys. Bupivacaine is the slowest of the AMIDE local anesthetics to be metabolized because it is up to 95% protein bound. This adds to its long length of action. Protein binding has an important effect on the distribution of drugs because only the free or unbound fraction is readily available to cross cell membranes, and therefore that's the only kind that can actually be metabolized at that time. The initial metabolic reactions that happen in the liver are the N-dealkylation and subsequent hydrolysis. The rate at which drug is metabolized is dependent on several factors. The amount of protein binding influences the amount of unbound drug delivered for liver metabolism. The amount of protein available to bind to the local anesthetic can vary on multiple factors such as cancer, surgery, trauma, smoking, uremia, and other drugs that a patient may be taking. Liver disease or decreased amount of the CYP450 enzyme also influences the length of time it takes for the body to metabolize AMIDE local anesthetics. Neonates are relatively deficient in plasma proteins that bind local anesthetics, and therefore they're more susceptible to toxicity as there is a larger free fraction of the drug in the plasma. Indications for bupivacaine: it is a long-duration local anesthetic. It can be used for surgical field anesthesia, post-op analgesia, for various pain conditions. It can be used for infiltration anesthesia, peripheral nerve block, neuraxial anesthesia, both epidural and spinal. The contraindications and concerns of bupivacaine. In pregnancy, do not use the 0.75% bupivacaine in obstetric epidurals. There have been reports of cardiac arrest with difficult resuscitation or death during use of bupivacaine hydrochloride for epidural anesthesia in obstetrical patients. In most cases, it has followed the administration of 0.75% bupivacaine, although the other concentrations of 0.25 and 0.5% bupivacaine are okay to use. Bupivacaine toxicity. Toxicity is a major concern. Typically, the more potent and lipophilic, the lower the dose is needed to achieve toxic reactions. Typical CNS symptoms are indicative of increasing toxicity. The different CNS symptoms are circummoral numbness, metallic taste, lightheadedness, dizziness, blurred vision, disorientation, shivering, leading to muscle twitching and seizures. CNS toxicity is generally noted with most local anesthetics well before cardiovascular toxicity. However, with bupivacaine, it is an exception, and the cardiovascular toxicity occurs quickly following the signs of CNS toxicity. Cardiovascular symptoms may include bradycardia, hypotension, dysrhythmias, and asystole. Secondary to the binding kinetics of bupivacaine, it is more prone to leading a complete cardiovascular collapse refractory to resuscitation attempts when compared to other local anesthetics. Treatment for bupivacaine toxicity. The best method of treating bupivacaine toxicity is prevention. Minimize the unintentional intravascular or intra-arterial injections by frequent aspiration for blood and use small test doses. Always inject slowly in small fractionated intervals. Every dose is a test dose. Treatment for toxicity is supportive. Stop the local anesthetic and maintain oxygenation and ventilation. Cardiopulmonary resuscitation should be instituted. Ventricular dysrhythmias may be difficult to treat and may require large amounts and multiple doses of electrical cardioversion, epinephrine, vasopressin, and amiodarone. Don't use lidocaine with people who have bupivacaine toxicity. Now, new and ongoing research is showing that intravenous lipid therapy has had some good benefits to toxicity with bupivacaine and other local anesthetics. Theoretically, it helps to remove the bupivacaine from its sites of action. There's no definite guidelines for therapy, and it's currently under investigation at multiple different sites. There's a couple YouTube videos that were pretty informative on what happens with bupivacaine toxicity and the effects that lipids have on it. Here are some links. LipidRescue.org is a site that has a lot of information on lipid rescue, therapy with lipid emulsions, And the following are different research papers on bupivacaine toxicity. References that were used in this presentation. Thank you for your time. I appreciate it.